Hello and welcome to Advanced Health Assessment 2, which includes diagnostic reasoning, and this is also part of the 5-day residency. So today we are delving deeply into diagnostic reasoning and decision making. By understanding the cognitive processes behind medical diagnosis, identifying some cognitive biases or pitfalls. This is very important to provide safer and accurate patient care. So, diagnosis is the fundamental art of identifying a disease by the signs and symptoms and test results of a patient. Because some of you may wonder, or may be asking yourself, why do we need to know about diagnostic reasoning? This is the very foundation of your differential diagnosis before you even start thinking about what differential diagnosis you need to make. So you may apply this reasoning to complicated patient cases, or for example, who present with competing diagnostic, differentials or possibilities. Clinical reasoning is like an umbrella term which also comprises diagnostic reasoning. So it does not end when a preliminary diagnosis is made. For example, as you see on this slide, it involves continuous gathering of information. You test for hypotheses, and then you reassess the patient after implementing the plan. If the plan does not improve, then you may return to your differential diagnosis and then collect more information and verify or modify your diagnosis to ensure patient safety. So a differential diagnosis is more than a simple list. It's not just coming up with a list of diagnoses. It's about prioritization. For example, you have to always list your top most probable, most possible, most likely diagnosis first, and then move on to the least likely diagnosis. So, what should be your most likely diagnosis? It's either life threatening or most harmful. That's what you prioritize. Using the mnemonic, which I presented here, Vindicate, is very important to help you prioritize your diagnosis. One of the most important components involved in diagnostic reasoning is illness scripts. Those are mental summaries which are specific for some clinical problems that patients may present with. And as you gain your clinical experience, your mental repository of illness scripts grows significantly, and you will end up developing these illness scripts effortlessly. So just to remember, patients usually never or rarely read the textbooks. So, but these are just to help you. What is the dual process theory of reasoning? This involves two cognitive systems which are distinct. System one is intuitive, and we all have intuition, or we are told at times to follow our gut. But how does that lead us to make those objective decisions? So system two is analytic or deliberate or conscious, especially when you encounter complex or unfamiliar cases. So that's why I mentioned you cannot always rely on your gut. You have to look at the evidence based processes to avoid the errors and ensure accurate and efficient diagnosis for your patients. Why do we learn about this diagnostic reasoning? It's because we all have biases. Those are known as cognitive biases. For example, some of them are known as anchoring, which occurs when we fixate on the very first piece of information that we receive. Another one is availability bias, which happens when we overestimate a disease likelihood based on recent or vivid or memorable cases that we have been treating. Another one is base rate neglect, which occurs when we ignore, for example, the actual statistical prevalence of a disease. So these are common biases, and you have more here, which you can review, like commission bias, a strong urge to do something or intervene rather than practicing watchful waiting. And you may have seen some providers or some, whether they're attending physicians or nurse practitioners in primary care, sometimes they want to order some labs which are unnecessary or imaging like X-ray or CT scan for things that we should be waiting to see what happens. Another common one is premature closure, which happens when you stop investigating too early. So we tend to give up if we don't get results. I'm pretty sure you probably watched those shows. For example, one of them is The House, when a team of academic physicians were meeting to review complex cases. But in real life, it doesn't happen quite often. Most providers give up too early and they don't refer some complex cases to the academic team of physicians to review them or providers. So, how do we actively reduce these biases? It's all about situational awareness, understanding the dynamic environment around us, report some errors, and do not engage in punishing those around us who make those mistakes, but give them some advice. So also practicing metacognition, which means like thinking about our own thought processes. That's very important too, because we might have those internal biases that we apply in real time. So despite the incredible technological advancements that we have in medicine, there are still some errors, some biases. And then at the bedside, we always have to pay attention. Bedside diagnosis still happens most of the times. I know we have telemedicine or telehealth, but it's only a portion of patients that are part of it. Maybe about 10%, 15%. So to accurately, diagnose a condition, especially the complex ones, it's very important to assess the patient in front of you. It doesn't necessarily to be at the bedside, but it can be in the clinic. We always have opportunities to assess them in person. I will not bore you much about this Bayes theorem in practice, but this is a mathematical concept which is foundational to diagnostic testing. So it helps quantify how new clinical evidence, like lab result or physical finding, changes the probability that a patient has a specific disease. So basically, I wanted to know about it because if you take your ANCC exam, this will be very helpful, especially about the likelihood of a disease or the prevalence. So likelihood ratio, those are the things you will have to become more familiar with. But this is probably too early to immerse into this right now. Same for sensitivity and specificity. How are they different? So, for example, a highly sensitive test correctly identifies patients with disease. So, use the mnemonic SN out, which is already here. So, when SN out is sensitive test, when negative rules out the disease. So a highly sensitive test, when it's negative, will rule out the disease. SPIN is another mnemonic to remind you that a highly specific test, when positive, rules in the disease. So out and then SPIN, or SN out. Because it yields a false positive. That's why SPIN, a highly specific test, when positive, rules in the disease. So we often use sensitive tests for initial screening and specific tests for diagnosis confirmation, which is very important to know. So the likelihood ratios are incredibly useful. I'm pretty sure you covered also these concepts in your statistics class. When we are making the decision, for example, in the clinic, so we use, for example, the rule of 15s, which provides excellent mental shortcut for adjusting your pretest probability without doing complex math. So, for example, I know I mentioned I will not, bore you much about this one, but for example, a likelihood ratio of 2 increases the probability. We are looking at this table here for the likelihood ratio, increases the probability by roughly 15%. For example, 5 by 30%, which is right here, and so on and so forth. So diagnostic decision making involves statistic thresholds. Those thresholds are the probability levels at which we decide the risk of a disease. And the treatment threshold too, those are also covered in this diagnostic decision making. But we'll go over these concepts more during your residency. So finally, solidifying your reasoning through proper documentation is very important, because if it's not documented or if it's not charted, it was not done. We all know about this one. So using like the SOAP format, which stands for subjective, objective assessment, and plan. This helps us organize information clearly. And this is something we'll talk about in week 2, the next week, in the next week's presentation. This is very important to avoid diagnostic errors, which account for 10 to 20% of adverse clinical events. So think about what we discussed today, like cognitive biases. How do they affect your judgment? And what should you not miss in the worst case scenario for a patient? And remember the mnemonics that we covered. How would they help you to prioritize your diagnosis or your differential diagnosis? I hope this is going to help you to develop your diagnostic reasoning skills. Thank you.